Hi, my name is Donara. I am a student nurse in California Career College. Today, we are going to be discussing about the somatic symptom disorders. Before we begin, let us discuss what somatic symptom disorder means. Somatic means physical symptoms. So physical symptoms can be such as fatigue, pain, point of excessive preoccupation, concern, and fear. So this state causes emotional distress and problem functioning. In other words, it is heightened awareness of certain bodily sensations combined with tendency to interpret the sensations as indicative of medical illness. To assess somatic symptom disorder, as a nurse, I would look at collecting data about nature, location, onset, characteristics, and duration of the symptom, exploring past history of adverse childhood events is very important. Nutrition, food balance, elimination needs are high priority of assessment due to complaint of GI distress, diarrhea, constipation, anorexia, determining current life, quality of life, social support, coping skills, including spirituality. Are the patients able to cope with the situation that they're in? Determining whether symptoms are under patient's voluntary control, because somatic symptoms are not under the individual's voluntary control. So exploring patient's cognitive style and ability to communicate feelings and needs is very important. Clinical features that will show the symptoms, either whether it's objective or subjective data. Subjective data is patient's concerns, and objective data is what we nurses measure, or the labs, or any observation that we find. So non-confidently aggressive behavior, aggregative and negative feedback about self, repeated unsuccessful life events, seeking of excessive reassurance, absence of support system, absorption of the own thoughts, disabling conditions, ineffective coping strategies with no access of social support, insufficient problem-solving skills. These are all the indications. Also vital signs, which will be the objective on what we measure, any necessary diagnostic test that needs to be done, patient's pain level. Does the patient have any shortness of breath, chest pain, dizziness? Nursing care plan, long-term and short-term goals and implementations. When the patients are able to identify level of anxiety in at least 3 situations, an encounter with IOP patient and staff, when patients are able to utilize therapeutic environment to increase express their feelings, and patients developing contact in conjunction with staff and plan for behavior change. Implementations, teach patients implementations. What we will do as nurses, we will teach patient techniques, the relaxation, breathing exercises to identify and manage their anxiety and self-help behavior, supporting and expressions of feelings with arts such as writing, music, drama playing. It encourages the promotion of feelings. As a nurse, or when we work with older patients, with elderly patients, it is very important to promote and also do it with them, so they also get involved with whether it's music, drama playing. This helps to promote their emotions. Developing a relationship with patients that include mutual agreement upon contact that details expected change in behavior. This will enhance self-direction and independent action for the patient. Reinforcing the patient's strength and problem-solving abilities, which will help the patient to realize that needs can be met without restoring the somatic symptoms. So helping the patient to advance in problem-solving ability and help them realize that their needs can be met without them feeling sorry or finding that there is something wrong with themselves. Shifting focus from somatic complaints to feelings of neutral topics, this will convey interest in patients as a person rather than in patient symptoms. This reduces the need to gain attention through the symptoms. Observing and recording frequency and intensity of somatic symptoms. Consistent primary care provider with regular patient visits is also very important, and group therapies, which will be extremely helpful as well. Course of treatment. What do we as nurses would expect doctors to do? Cognitive behavior therapy is often one of the treatments of choice. It helps the patients to learn new ways to cope with and solve their problems as they gain a deeper understanding of their condition or circumstances. The use of screening instruments, such as the Patient Health Questionnaire 15, are considered the patients with suspected somatic symptom disorder. Pharmacological interventions are also considered a course of treatment, such as antidepressants, antiepileptics, antipsychotics, natural products. Effectiveness of many of these treatments has limited support, and increasing patients' awareness that the possibility of psychological factors are involved in the symptoms. 3 nursing diagnoses, psychiatric nursing diagnoses, include ineffective coping, risk for loneliness, social isolation, psychopharmacological and nursing considerations, what we as nurses would consider: tricyclic antidepressants, selective serotonin reuptake inhibitors, medications. These are medications that are used in somatic symptom disorders directly by reducing depressive symptoms and subsequent somatic responses. Short-term use of benzodiazepines must be monitored very carefully due to risk of the dependence. Amitriptyline, the St. John's wort, which is also known as the happy pill, are also effective pharmacological treatments for somatic symptom disorders. Avoiding other antidepressants like monoamine oxidase inhibitors, Wellbutrin, anticonvulsants, antipsychotics, these are ineffective for the treatment of somatic symptom disorder. Outcomes and identification for long-term goals. We want to consider that the term a long-term goal where patients will be able to identify and express their emotions without physical symptoms. So patients are able to identify a support system, willing to call on others for assistance. Goals, whether goals met or not met, writing measurable behavior outcomes clearly and realistically is very important for a nurse to practice. Often goals and outcomes are partially met. So patients will report continuing presence of somatic symptoms, and we will discuss that why. And patients are often less concerned though about the symptoms. So we have talked about that somatic symptom disorder has to do with the focus on the physical symptoms, where it takes to the point of excessive concern and worry and fear. This tells me that as a nurse, I should be working with a patient on giving attention on their mind, working with their mind. When they identify themselves with excessive worry, that excessive worries are thoughts. And when they identify themselves with this excessive thoughts and worries, which lead to emotional distress and function, this tells me that as a nurse, I would work with them on certain exercises of paying attention to where the thought is coming. Where are they originating? Why is there fear? Whether it has to do with childhood experiences, whether they have had a certain life situation experience currently, which led them to have this excessive thoughts and worrying. And I will explain on this technique a little more on as we move on. Another disorder that falls under the somatic symptom disorders are illness anxiety disorder. It is characterized by extreme worry and fear about the possibility of having a disease. This leads to frequent scanning of the body for signs and symptoms. This is mostly obsessive, as thoughts about illness may be invasive and hard to dismiss, even when patients realize that their fears are realistic. This also has to do with mind, specifically with the thoughts, excessive thoughts. Collecting data again about nature, location, onset, characteristic, duration, accessing their current biological and physiological needs, determining their quality of life, social support. These are all important assessments that needs to be done by the nurse. Individuals' clinical features, subjective and subjective data that we might notice and the patient says. Individual has a high level of anxiety about health and is easily alarmed about the personal health status. Individuals perform excessive health-related behavior and show maladaptive avoidance. They have been preoccupied with illness for at least 6 months. Vital signs, any necessary diagnostic test that needs to be measured. Also moist hands, perspiring forehead, strained voice, wide eyes, and restlessness. Mild to moderate agitation. These are all indications of clinical features. Nursing care plan, long-term and short-term goals and implementations. Patients will be able to identify the relationship between stress and physical symptoms. Patients will be verbally express their emotional feelings. They can make a list of contacts and phone numbers of community resources of interest that interests his or resources of interest to her or him. Patients will demonstrate alternative ways to deal with stress, anxiety, and other feelings. Patients will demonstrate healthier behavior regarding rest, activity, nutritional intake. Course of treatment, what do we expect doctors to do? Cognitive behavioral therapy is effective in the treatment of illness anxiety disorder. Pharmacotherapy, excessive exercise, which increases psychological well-being, improves mood, reduces tension, increase in a patient's awareness of the possibility that psychological factors are involved in the symptoms. And of course, group therapy is also extremely helpful. 3 psychiatric nursing diagnoses that have to do with this disorder: ineffective coping, hopelessness, and anxiety. Psychopharmacologic and nursing considerations. Selective serotonin reuptake inhibitors. These are typically used for depressive anxiety disorder or anxiety comorbid with anxiety on this disorder, although in some cases they alleviate anxiety, illness, disorder symptoms more. So beta-adrenergic receptor blocking agonists are also used to relieve symptoms of autonomic arousal. Benzodiazepines indicate the treatment of panic attacks, commonly comorbid with illness anxiety disorder, also used with caution because the patients can have an increased risks for substance abuse or dependence. Antipsychotics also have been shown to reduce morbidity associated with this disorder, particularly in the presence of comorbid anxiety worries that mimic obsession or delusions. Outcomes and identifications, long-term goals, and patients are able to take more control over their life situations. The planned techniques by the nurse will help the patient negotiate interpersonal situations and foster self-assurance. Patients are able to verbalize feelings in a non-threatening environment that helps them to come to terms with the unresolved issues. Whether goals met or not met, writing measurable behavioral outcomes clearly and realistically is again extremely important by the nurse to practice. Often goals and outcomes are partially met. Patients will report continued presence of anxiety illness. We will discuss this why. And patients are often less concerned about the symptoms. We have discussed that illness anxiety disorder has to do with extreme worry and fear about the possibility of having the disease. This tells me that the patient is having fear in the mind. As a nurse, again, I would work with the patient on focusing on the aspects of the mind, using awareness techniques that focus on the origin of fear. I would recommend starting in one-on-one treatment with the alliance of the patient, of course, a 30-minute practice that sitting and looking at these thoughts that are coming. And instead of identifying with these thoughts and feeling extreme sadness or anxiety, being able to look at them from the side, like watching a movie. Thoughts are passing, and teaching a patient to look at these thoughts as a movie by putting awareness on where does the thought come from. When the patient figures out that thought, where does the thought comes from, which is not easy to figure out, little by little, they would focus on who is observing those thoughts. These thoughts, after 1 second, become a memory. It passed because another thought appears. By explaining this to the patient, that a thought that we just had, even just now, it passed. And one second later, we have a different thought. And the previous thought that we had becomes a memory. It's stored in our memory. And remembering these thoughts and being angry about it and worrying about it is just use of excessive energy, which causes anxiety. So I would teach the patient on focusing energy in different direction and using therapeutic techniques, relaxation techniques on helping the patient to observe the thoughts, to observe them, look at them as a movie instead of identifying with them and causing all this illness disorders, which are mind disorders. Conversion disorder is another disorder that falls under somatic symptom disorders. This is known as the functional neurological disorder. It proves itself as a neurological symptom in absence of neurological diagnosis. So it is remarked by the presence of deficits in voluntary motor or sensory function, including paralysis, blindness, movement disorder, gait disorder, and numbness. So emotional conflict or stressors are transferred to physical symptoms. Patients with conversion disorder have an abnormal patterns of cerebral activation, and they show lack of emotion concern about often dramatic symptoms, for instance, sudden blindness. To assess for the conversion disorder, again, as a nurse, I would collect data about nature, location, onset, characteristics, duration of the symptoms, how long are they happening, exploring past medical and psychosocial history, have they had any traumatizing events, exploring patients' cognitive style and their ability to communicate feelings. Are they able to communicate their feelings, or are they holding them inside? Are they able to speak out what they want to say? Assessing for level of consciousness, orientation, speech, facial symmetry, motor, sensory function, and reflex activity. Accessing cranial nerves is very important. Cerebral function, reflex activity, covered in a comprehensive neurological assessment. Clinical features, which include loss of voluntary motor, impaired coordination, balance, paralysis, difficulty swallowing, urinary retention, seizures, sensory functions, loss of touch, sensation, sudden blindness, deafness, aphonia, which is loss of voice, anosmia, which is loss of smell, appears to represent physiology dysfunction, but related to psychological conflict, followed by the perceived stressful experience. Label indifference, lack of emotional concern about sudden blindness or other major impairment. Is the patient having hallucinations? MRI abnormal pattern of cerebral activation? These are all subjective and objective data that the nurse is implementing, that the nurse is looking for and observing. Nursing plan of care, long-term and short-term goals. This is an implementations. So here we explain is the patient will be able to identify relationship between stress and physical symptoms. The patient will verbally express emotional feelings. Patient will follow an established daily routine. They will demonstrate alternative ways to deal with stress, anxiety, and other feelings. And they demonstrate healthier behavior regarding rest, activity, and nutritional intake. Course of treatment, what do we as nurses expect doctors to do? Cognitive behavior therapy is often the treatment of choice. This helps the patient learn new ways to cope with and solve their problems as they gain deeper understanding of their condition or circumstances. Psychoanalysis, hypnosis, behavioral relaxations, physical therapy, pharmacotherapy, psychotherapy, these are all courses of treatment that we would expect doctors to give. The nursing diagnosis, ineffective coping related to inadequate coping skills, self-care deficit, which could be related to paralysis of the body, pain, discomfort, deficient knowledge related to lack of interest in learning and severe anxiety. Pharmacologic and nursing considerations, tricyclic antidepressants, haloperidol, electroconvulsive therapy, which I think is a very aggressive therapy, and selective serotonin reuptake inhibitors. Long-term goals, the patient will be able to take more control over life situations. The planned technique by the nurse will help the person negotiate interpersonal situation and foster self-assurance. Also, patients are able to verbalize feelings in non-threatening environment that helps them to overcome in terms with unresolved issues. And patients able to demonstrate alternative ways, again, to deal with stress, anxiety, and feelings. Whether goals met or not were met, again, nurse needs to be writing measurable behavior outcomes clearly and realistically. Patients will continue to see the nurse therapist weekly and work on assertive skills, identification and expression of feelings. Patient will continue on joining group therapies. In conclusion, conversion, we discussed that conversion disorder is a mental condition in which a person has blindness, paralysis, other neurological symptoms that cannot be explained by a medical evaluation. As a nurse for this disorder, I would take priority on safety of the patient. Are they able to take care of themselves? Providing them coping strategies. Can they cope with the uncomfortable for them situation? Again, I would work with patients with mind instead of identifying with thoughts, helping the patient to provide therapeutic techniques, therapeutic practices with mind on sitting down and one by one catching where does this fear come from, paying attention, observing their thoughts, observing how it's hurting them. Where does the stress response comes from? Where does the stress response hit in the body? Going over the pathophysiology with them a little bit to explain and educate on the understanding of their the symptoms they're having or the thoughts that they're having. Thank you very much. I hope you enjoyed this video and I hope this was helpful.